Test this person's lower limbs neurologically, the motor system. Look, tone, power, coordination, reflexes, and gait. Look, tone, power, coordination, reflexes, and gait. Look. Ensure adequate exposure. Have the patient rest their hands by their sides. Look for major deformity or asymmetry in muscle bulk in the legs. Proximally, look at quadriceps. Big muscles are the best in which to observe generalized fasciculations. However, length-dependent neurogenic wasting is best detected distally, and the most useful muscle in the leg to observe this in is the tibialis anterior, TA. TA lies along the lateral side of the edge of the tibia. If TA wastes, the edge of the tibia becomes sharper. If you suspect wasting, feel the muscle bulk of TA and the tibial edge. Compare both sides. Are the feet clawed, implying weakness of intrinsic foot muscles? Is it a fixed deformity? Pes cavus. Tone. First we test muscle tone about the knees. Have you got any pain in your knees or your hips? Relax your legs completely. Let your legs go dead. Flick the knee up off the bed with a quick, forceful movement. The heel should stay on the bed. If it does not, but you suspect that this may be due to the patient having problems relaxing, then try once more to get them to relax completely. Let your legs go dead. Next, we test tone about the ankle. Roll the leg side to side at the knees. The ankle should just lag behind the movement of the leg. Now test for clonus. Place the leg in the same position that you would use to test for the ankle jerk. The leg is externally rotated and slightly flexed at the knee. Do your best to relax the patient. With a single jerk, not too forceful, dorsiflex the foot at the ankle and hold it there for a few seconds. If clonus occurs, hold the dorsiflex position until it stops after a few beats, or you can conclude that it is sustained clonus. Beware, the patient may find this uncomfortable, so go gently and do not prolong the demonstration of clonus. If the clonus does not stop when you let go, stroke the top of the foot, putting it back into the plantar flex position. The clonus should then settle. Do not go testing patellar clonus, it is too subtle a sign for the general examination. Power. As in the upper limbs, we examine power about successive joints from proximal to distal. Hip flexion and extension. Lift this leg as high as you can. Then push down on it with reasonable force. You may slightly flex the leg at the knee before applying that force, reducing the contribution of quadriceps and concentrating the testing on iliopsoas. Do not pin the leg against the bed and expect them to be able to lift it. Push your leg into the bed, don't let me lift it. Note that this is the best we can do to test hip extension while the patient is lying on the bed. To test it in more detail, we would have to lie them on their front, which we do not routinely do. Knee flexion and extension. Make sure you use your free hand to help stabilize the leg about the knee. Keep your leg bent and don't let me straighten it. If this fails, rephrase the instruction as, bring your heel towards your bottom. Now straighten your leg, don't let me bend it. If this fails, try, kick me away. Note that the patient will naturally receive a pressure cue on how you want them to resist you from how you start applying the force. Build it up slowly, and they will get the cue that they have to resist. Ankle dorsiflexion and plantar flexion. Before you apply resistance, see that they have a full range of ankle movements. Point your toes down as far as you can. Now roll your ankles back as far as you can. Hold it there. Push down on each foot at a time. Now place your hand under the foot. Push down against me. Note that gastrocnemius is a very strong muscle. If you suspect weakness of gastrocnemius, it is best confirmed by asking the patient to stand on their toes. If testing in detail, we would test ankle inversion and eversion. For each, position the foot first, then ask them to hold the position against resistance. Coordination. Heel-shin coordination. Show the patient what you would like them to do by moving their leg. I'd like you to take your foot and place it on your shin like this. Then move it all the way down and make a big bicycle movement all the way back and repeat the sequence. Okay. Do not allow them to slide their leg up and down the shin unless they are too weak to perform the more complicated task. Of course, apparent incoordination or ataxia has to be interpreted in the context of any weakness. Reflexes. Knee jerks. Lift the knee by placing your free hand under the knee and on top of the opposite knee. Feel for the rectus femoris tendon insertion just below the patella. Then strike it with the hammer. Repeat for the other side. Again, if you cannot elicit the knee jerk, apply reinforcement. Put your hands together like this. When I say pull, pull. Pull. And relax. Ankle jerks. Positioning on the couch is very important. Slightly externally rotate the leg at the hip and flex at the knee. Hold the foot with your free hand and just before you're about to strike the Achilles tendon with the hammer, stretch it out a little by dorsiflexing the foot. Note, do not expect a dramatic ankle jerk, especially in the elderly, but try not to miss the response that you have elicited. When the ankle jerk appears to be absent, it is often because of inadequate contact being made with the Achilles tendon. If you suspect this is the case, do not apply reinforcement, but either get the patient to sit on the side of the bed and test the reflexes in that position, or try the plantar tap, a second best indirect method of eliciting the ankle jerk. If the patient tenses their ankle thinking that they are being helpful, it will block the ankle jerk altogether. Get them to relax. Plantar response. By definition, the plantar response is a nociceptive response, and the stimulus is uncomfortable. But try to keep the discomfort to a minimum. Be especially careful in those with friable skin. Use an orange stick to elicit the plantar response. With your free hand, hold the patient's ankle comfortably, aiming to relax the patient. If the patient does not relax their foot, encourage them to do so. This will be uncomfortable, but I'll keep it brief. Close your eyes. Stimulate the sole of the foot with the orange stick, starting laterally and far back. Move forward in an arc which eventually sweeps medially just before the metatarsal heads. Often the response, either flexor or extensor, is immediate. If so, stop there, rather than exposing the patient to more discomfort. Try to perform this test only once. If you prolong testing, this will result in a withdrawal response, which is not the same as an extensor plantar. Gait. Do not forget to walk the patient to complete the examination. If they are unable to walk, ask them if they could possibly stand for you. Observe gait. Tandem walking. Can you now walk one foot in front of the other, like this? Romberg's test. Now put your feet together like this and close your eyes. Be prepared to catch them. Observe gait for signs of a broad-based ataxic gait, either cerebellar or sensory ataxia, a stiff wading spastic gait, a high stepping gait seen in bilateral foot drop, a Parkinsonian gait with loss of arm swing, a Trendelenburg gait due to weak hip abductors.